Great. Okay. So I'll introduce myself in a couple of slides and you'll understand why when I do that. So today I've decided to present on catheter-based regional anesthesia, an opioid sparing technique. And so we'll just kind of go through a few different things. So our learning objectives today, to look a little bit at post-operative pain review, risk factors for pain as well. And so basically, anything that we do is kind of like, why do we care? Well, we care because post-operative pain, especially uncontrolled post-operative pain, is actually pretty bad. There's emerging literature on that kind of all the time. And so what can we do a little bit better than we did before in regards to this? So there's also, then we'll go into an overview of what regional anesthesia is, benefits and risks of nerve blocks, talk a little bit about single shot nerve block, and then get into the conflicting based peripheral blocks or catheter based peripheral blocks, and talk a little bit about conflicting research in the world of regional anesthesia and how we kind of navigate that, and then emerging uses, which actually has more to do with chronic pain than anything else. So it's kind of exciting. Disclosures. So I don't have any professional disclosures. I'm not funded by anybody other than an employee of the SHA. I'm not involved in any other research either. So my one disclosure I do want to make though is I am not an anesthesiologist. So this is not my area necessarily of expertise. So go easy on me with the questions. I am a nurse practitioner. I work mainly with the opioid and pain consultation service, which is a newer service that we've started here in September, looking mostly at acute variants of pain in the hospital, some acute on chronic pain as well, lots of post-operative pain as well. So that's kind of what our program, what our consult service looks like. And then in the larger scheme of things, I'm part of kind of the opioid stewardship program and then the clinical appropriateness and stewardship program. And so that program is always looking at how do we do things, why do we do it that way, and can we do it better? And so I'm not an expert. Why did I choose this topic if I'm not an expert? Because people keep saying to me, this is why we need a catheter program. And I wasn't 100% sure what exactly that kind of meant. So I decided to dive into the literature a little bit. So okay, postoperative pain. So postoperative pain is reported as an expected occurrence with surgery. We know if you have surgery, you're probably going to have some degree of pain. In the United States, studies regarding the incidence of uncontrolled pain postoperatively in particular are very variable. Some say it's an incidence of 20%, some say 80%. And that just kind of goes along with the literature on pain in general. It's very inconsistent. Factors affecting pain. So type of surgery. So specific type of surgeries are just naturally more painful. So abdominal surgeries, upper limb surgeries, spine surgeries. Length of surgery. So surgery that lasts for longer than 2 hours is typically associated with more pain postoperatively. Analgesia and anesthetic use preoperatively and intraoperatively is a big factor. So Celebrex, for example, preoperative Celebrex, it can reduce pain. Preoperatively, because it's a COX-2 inhibitor, the COX-2 levels will increase with trauma and with surgery. And so Celebrex is actually part of what we call a multimodal strategy that helps to kind of counteract that. So there's actually really good evidence for preoperative Celebrex in particular to decrease postoperative pain scores. Sometimes we'll give gabapentin preoperatively as well to help decrease some of that postoperative pain. Intraoperative use of dexmedetomidine, which is a sedative. It's an alpha-2 adrenal receptor agonist. It also is shown to decrease postoperative pain scores. So we don't use that on the wards. They can use that in the OR as well as I believe in intensive care. Age, so younger age is actually associated with more pain. Surgery on the same day of admission. So if you come in and then they're like, hey, you have to go for surgery, those people tend to have more pain post-operatively. That probably has more to do with like coping and stress than anything else, and length of stay in hospital. And length of stay in hospital, I mean, again, when you look at the literature, is that because you had a surgery that required you to stay in hospital that long? And that surgery in itself is a more major surgery that increases pain. And, again, that's why the literature is exceedingly variable. Okay, so risk factors for poorly controlled pain. So there are some things that we know make patients more at risk for hard to control pain. So history of physical, sexual, and emotional abuse is certainly a risk factor for worsening pain experiences. A history of anxiety, history of drug and alcohol abuse, current opioid use prior to having surgery or having an accident that gives you acute pain. Other psychological conditions, so post-traumatic stress disorder, borderline personality disorder, smoking, high BMI, and the presence of preoperative pain, all kind of are risk factors for poorly controlled pain. So we know that. I want you to kind of keep those things in mind when we talk about patient selection and why we make the decisions that we do. So consequences of, consequences of uncontrolled postoperative pain. So why do we care? Like, they have uncontrolled post-op pain. Why, why is that a big issue? So there's actually increased morbidity. So, more diseases that happen with this. So things like paralytic iliasis post-operatively because people aren't moving around, higher incidences of pneumonia and atelectasis because people aren't taking big breaths. There's actual like disease complications that happen because people's pain is not well controlled. Decreased functional ability, decreased quality of life. Nobody likes to be in pain. It's not a very pleasant experience. Increased length of stay, which we know in this current climate, the hospital beds are at a premium. Prolonged opioid use. So certainly there's risks that go along with prolonged opioid use or having to use opioids longer than kind of what's expected. Increased system costs and increased incidence of development of chronic pain. So there is a link between poorly controlled acute pain, poorly controlled post-operative pain, and the subsequent development of a chronic pain condition down the road. So it is very important to treat this aggressively. So regional anesthesia is one of those techniques of which we can treat particularly, post-operative pain is what we'll focus on today. So overall, when we look at acute pain management strategies, there's a lot of literature, there's a lot of programming out there about multimodal analgesia strategies, and then as well enhanced recovery after surgery strategies. And so this is, people starting to recognize the importance of acute pain treatment and create just basically multi-pronged strategies about that. So it can be things like, utilization of different kinds of medications, so opioids, gabapentinoids, maybe medications for anxiety, a lot of discussions with patients about like expectations of pain and kind of what they can expect. And those honest conversations can actually go a really long way. Looking at things that we haven't quite started up in Regina, so lidocaine infusions, ketamine infusions, and then, of course, using regional anesthesia. And also what you do inside the OR makes a difference too. So it's kind of this multi-pronged approach to perioperative pain management that we're starting to look at. So we don't just have to give people like handfuls and handfuls of morphine and out the door you go. So there's three kinds of main regional anesthesia, so spinal anesthetic, epidural anesthetic, and nerve blocks. So spinal and epidural anesthetics sometimes are just referred to as neuroaxial analgesia. And so we'll go through the three of these here. So a spinal anesthesia is a small needle and it enters the subarachnoid space, and a small amount of anesthetic is then injected into the cerebral spinal fluid. Numbness will start at the feet and move upwards. This is a beneficial procedure for procedures that are below the umbilicus, so amputations, orthopedic surgeries, pelvic surgeries, and C-sections. there's actually quite good evidence out there that a preoperative spinal done while the patient is awake for a planned amputation, as long as it's not an amputation for infection, even if they undergo a general for their surgery, their pain outcomes and their phantom limb pain outcomes are actually improved. So there is lots of uses just in terms of just long-term pain management strategy. Absolute contraindications. So if a patient is unable to consent, so either they've got dementia or, delirium, maybe they're unconscious, then we can't do a spinal. Increased intracranial pressure. So this is usually the intracranial pressure that we see with intracranial mass. And then as well, infection at the site of procedure, because you don't want to spread that infection into the cerebral spinal fluid. Relative contraindications of this. So pre-existing neurological disease, multiple sclerosis. This actually has more to do with some of the stuff that they can put in spinal anesthesia as associated with relapses. So always kind of looking at diseases that people have. Severe hypovolemia, thrombocytopenia, and coagulopathy. So of course, risk of bleeding anytime you do any interventional procedures. Patients on anticoagulations, severe mitral and aortic stenosis, and HOCM. And that comes down to like a preload, afterload effect with the spinal anesthetic. So these are all things that the anesthesiologist looks at and makes a decision whether or not the spinal anesthetic is an appropriate choice. Then we have epidural anesthesia. So this is actually, it's quite similar in procedure to a spinal anesthetic, but it doesn't enter the CSF. And this is somewhat of a catheter nerve block, sort of. The catheter is a place inside the epidural space, though. It does remain in place to deliver ongoing anesthetic and pain relief. The most common example of this is patients that might be familiar with this for labor and delivery. Absolute contraindications, patient refusal, and severe coagulopathy. The relative contraindications would be very similar to what a spinal is. Epidural anesthesia actually has uses outside of labor and delivery. So if you guys remember when there was a epidural shortage and the SHA made a triaging plan, it didn't just, obviously the patient group that was most concerned was the women who were coming up for delivery, but it didn't just affect those people. There's actually mortality benefits. Some of the major surgeries that they use epidurals for, which actually show that they have lower rates of death, lower rates of atrial fibrillation, pneumonia through using an epidural. So it actually was a pretty big deal when we had an epidural shortage for more than one reason. So this is just kind of a difference between a spinal and an epidural administration. So you can see there, the spinal anesthetic actually goes in like a little bit further, pretty close to the spinal nerves there. And then the epidural actually goes into that epidural space, so a little bit shallower, and then a catheter is left in place, particularly for the epidural. So a little bit of a difference between the two. I know people were really, really panicked that we're going to have C-sections and there was an epidural shortage, but actually it's a completely different modality for planned C-sections. So then we get into peripheral nerve block. So this is when a local anesthetic solution is injected close to a nerve, and it blocks the transition of nerve impulses distally, so going out. And then this then blocks the pain sensation to the cortex, so the interpretation of that pain response by the brain. This can block motor function as well as pain sensation to the area that the nerve supplies. So sometimes that's good. Sometimes we want to block some motor function. Sometimes it's not so good. So, sometimes with some of your ambulatory surgeries, particularly in your day surgeries with your lower limbs, you have to be careful that you don't do specific blocks, because it actually increases the patient's risk of falling because their leg doesn't work as well post-operatively. So, and so it can be delivered via a single injection or through the use of a catheter, which is what my presentation is on today. So this is an example of just a single shot nerve block. So you can see there's a couple of nerves. And so it kind of gets injected in and around the nerve. It's not into the nerve. And then that would end up causing numbness to that portion of the hand that those nerves supply. What are the benefits of a nerve block? So it's certainly an alternative to a general anesthetic. So there are patients that aren't great candidates for general anesthetics. Patients who maybe have really, really bad sleep apnea, patients who have some delirium preoperatively, really bad pulmonary lung disease. There are some people that just would do better without a general anesthetic, and so the nerve blocks give them some of them that option, as well as you can use a nerve block in addition to a general anesthetic. And the reason for that is for improved postoperative pain control. So we had a patient that had a below knee amputation, and he got a general and a nerve block, because the general is obviously, because the surgery is quite significant surgery, and then the nerve block was for postoperative pain control. So improved postoperative pain control is the main goal of a nerve block. Less use of opioids required in the immediate postoperative period. So if you've got numbness to the area, you can't really feel it, then you don't really need particularly opioids or a lot of pain medications while that block is in place. There's less incidence of postoperative nausea and vomiting because you don't have to go through a general and the medications that come with a general. Potential earlier discharge. So, sometimes people bounce back a little quicker because they're not recovering from a general. And it's got a pretty high success rate of about 90%, which is wildly is because of ultrasound technology. There are some risks though, right? So failure of block. So when you have a success rate of 90%, 10% of the time it doesn't work. And then the patient then has to go under a general for their surgery. Bleeding, infection, damage to surrounding structures. So anytime, we're injecting into the body, there is always that risk. Permanent nerve injury, systemic toxicity from local anesthetic. So that's when you start to get high levels of the local anesthetic kind of circulating in your body. And this can cause confusion, agitation, a metallic taste, ringing in the ears, and most seriously, seizures and cardiac arrest. So it is a big deal. Localized skin and side effects, and there are some contraindications. So again, inability of patient to cooperate with procedure, because if they're moving around, it's not a very safe procedure. Active infection, habitus or obesity obstructing the ultrasound guidance, and anticoagulation is a relative contraindication. It really depends what nerve block you're doing. Risk of serious risk is around 1%, according to the literature. Single shot peripheral nerve block. So this is a one-time injection of local anesthetic to block nerve impulses. So duration of action, it'll depend a little bit on type of local anesthetic used and just patient variability. Ropivacaine is usually around 7 to 15 hours, which is what Regina typically uses. Bupivacaine is in the literature as well, and it's 9 to 20 hours. There are adjunctive agents that you can add to your injections, like steroids like methylprednisolone, dexamethasone, and dexmedetomidine. It can increase the duration of action of single shot blocks. With single shot peripheral nerve blocks, we do always have to consider the risk of rebound pain. So rebound pain occurs when the block wears off, and in fact can be more severe than if they had gotten a general and gotten pain medication right from the beginning. There's a couple of reasons for this. And there's lots of literature on it, but a big main reason is that patients, when they're not feeling pain, don't take pain medications, and people typically don't want to take opioids and morphine if they don't have to, and so they don't take it, and then their block starts to wear off, and then their block wears off, and they're 1 day post-op, and they have absolutely nothing on board. So this has actually been a concern raised with some of our surgical colleagues, that they're getting calls in their office of patients whose blocks have worn off and they're at home. They show up in Emerge for pain control. And so part of, again, being part of the clinical appropriateness and stewardship program, this is something that we're hoping to look at likely in the new year, is doing some patient planning around single shot peripheral nerve blocks when people are going to go home, to make that a little bit better for everybody. So then we can do catheter peripheral nerve blocks. So there's two main techniques for this. You can go through the needle or over the needle. It's a small catheter that sits in the space near a nerve, and it delivers local anesthetics. But the difference is the catheter can stay in place for about 2 to 7 days. So it's not like a single shot block where you go home and it wears off. We have the ability to extend that anesthetic benefit longer when they have a peripheral nerve block, catheter-based peripheral nerve. So this is what the equipment typically looks like. So you can see there, it's similar to almost like an IV. And the top left corner there, you have the needle that introduces it into the skin. And then you would pull that back. And what is in place is that really kind of tiny, small catheter that stays in place next to the nerve. So we use ultrasound typically to do this. Most of the anesthesiologists as well will use ultrasound for their single shot nerve block. It is the gold standard of catheter placement, includes the use of ultrasound. Higher rate of successful placement, less time for placement, less procedural discomfort, lower risk of vascular penetration, which is great because then otherwise you get the systemic toxicity of the anesthetic, and lower risk of injury. So most people do use ultrasound for all of their nerve blocks here. There's three different kinds of regimens. So one is a basal infusion of a local anesthetic. So it's just a really low dose, kind of infusing on a pump through the catheter. Then bolus infusion. So you can do like this amount every however many hours, and then a blend of basal and bolus. There's been a lot of randomized control trials that have looked at the difference between basal and bolus, and they didn't really find a statistically different significance other than how much anesthetic got used. So single shot versus catheter based. So I looked at a 2012 meta-analysis, and it compared a single shot and a catheter peripheral nerve block. It looked at pain scores, opioid use satisfaction, and adverse effects. There was 21 randomized control trials, not huge patient volumes. As you can see, not very many of the studies were high quality. And so what did it say? So it showed that catheters did show statistically significant lower pain scores on postoperative day 0. And that was maintained on day 1 and day 2, but not statistically significant on day 3. So certainly there is a benefit for the first 3 days. There might not be a big benefit after day 3. And then, your risk of infection from catheter replacement will start to go up. So things to look at there. It did have improved patient satisfaction scores, so patients typically were quite satisfied with their pain control. Same thing, opioid use, that benefit of decreased opioid use was maintained all the way to post-op day 3, and then on day 3 it kind of went away as well, which makes sense if that's when the benefit wears off. They are associated with lower rates of nausea and vomiting versus single shot. It probably has mostly to do with the amount needed. So when you're doing a delivery via a catheter, you can have a lower concentration, lower amount going in. There's a large body of conflicting evidence on whether catheter-based nerve blocks had higher rates of complications than single shots. And overall, the complications include catheter infection, bleeding, local anesthetic, systemic toxicity, and nerve injury. Sounds great. Let's start tomorrow. So currently we don't do catheter nerve blocks in Regina routinely in acute care. To do this, infrastructure needs to be in place. So we would need anesthesiologist training to ensure they kind of know how to do this, OR staff training in terms of support, post-op management, catheter selection and procurement. So, different companies have different catheters, pharmacy protocols to be developed, infusion protocols to be developed, pump procurement, nursing protocols, and education. So it is quite an undertaking to start a catheter program, but multimodal analgesia is needed to adequately treat acute pain, and this lessens the chance of adverse outcomes and the development of chronic pain. So I'm going to talk a little bit about patient selection. So if you start to look at the literature on general regional anesthetics, single shot nerve blocks, catheter nerve blocks, the literature is actually quite poor and it's quite variable. There was one study that definitively said single shot works just as well with lower cost and lower and lower complication rate than catheter based. So you shouldn't be doing catheter based. You should only do single shot. And then you take a look at this study, and they used 160 participants for the single shot and like 800 participants for the catheter base. Well, like that's not really a good way to study. If you study more and more people, you are going to find higher chances of complications. So they had 2% complication rate with the single shot and 10% with the catheter based. And so that was their conclusion. And in fact, some people wrote into the editor, some physicians, and said, this is a really dumb study and has lots of study limitations. So I don't really think this is what we're going to use in clinical practice. I think when it comes down to deciding pain strategies and is it worth the cost? Is it worth the risks? Is the benefit there? It comes down to patient selection. And so this is something that I think we're starting to get a little bit better of. There's starting to be more evidence to support kind of individualization of care. And in particular, pain is something that needs to be individualized. So if we look back at risk factors, and you have somebody who maybe has a history of anxiety, they're female, they're 22 years old, and they're going for major surgery, and then you compare, a 65-year-old farmer who toughed it out till the end of harvest, you're going to get two different pain scores, even for the same procedure. And so we know that. And so what we use to treat one patient is not the same as what we use to treat another patient. And so that's why multimodal approaches are so important, because we have to have this huge toolkit at our disposal to get this done. So we don't do catheter peripheral nerve blocks in Regina right now, but I actually think that we should start looking at this a little bit closer. Obviously, there's, quite a bit of infrastructure that needs to be in place. I don't think the cost is particularly huge. The catheter kits, I think, are maybe, $25 a catheter. Ropivacaine is pretty cheap. Local anesthetics typically are. The pumps are, a few $100s, but once you buy the pumps are kind of there. But I do think that this would be a really great option for some of our patients. In particular, people who have complete shoulder replacements tend to have a pile of pain. And so blocking that pain for a few days while in that most acute phase is really important. Patients that we know are going to do poorly post-operatively, so they have a history of post-traumatic stress disorder, they have a history of anxiety, they're a young female, to be able to block their pain sensations for a few days is probably worth it. If you have somebody who is in a traumatic accident and they're going to come out of the OR missing a leg, again, if we can block their pain for 3 days, that to me is worth it. And if we don't have to do the complications of opioids, right? So you're recovering from surgery, you've already got slow gastric motility from the surgical process itself, you're maybe not eating and drinking properly, maybe you've got post-operative nausea, and then we throw a bunch of opioids at you because it's our only option. Is that always a good thing? No, it's not. And so we need to start looking at other ways to treat acute pain, especially inside hospital, because they exist. We just have to put them into place. So I'm hoping that because our program is actually relatively new, hopefully some of these things can start. And they may take a few years, but we can start looking at how do we do things and can we do it a little bit better. So again, I just recommend reading the literature with caution. There wasn't anything glaring in the literature to say this is incredibly dangerous. It just single shot versus catheter based wasn't always clear which one was better. And again, it comes down to that patient selection. And you can't run studies on that very easily. It's very difficult to control the co-founders. Emerging evidence for future use. So this is actually more for our chronic pain peeps on the line here. So there's a few things. So there's actually lots of places that are doing catheter peripheral nerve blocks in ambulatory settings. So sending patients home after orthopedic surgeries with a nerve block in place for 3 days. That goes with a portable balloon or a portable pump, which is a really cool idea. I think we're probably pretty far away from doing that here, but it exists in places like Stanford and bigger centers. Cancer pain. So there's actually quite a bit of case reports on using catheter nerve blocks in pediatric cancer pain. So there was a case report of 3 patients with osteosarcoma. And so, as you probably are familiar, osteosarcoma can come with lots of fractures. It's a really painful condition. So 3 cases were studied. 1 patient, as long as 41 days, had a catheter in place with, I would assume, bolus. Local anesthetic, and he didn't have any complications, and had, you know, a month and a half of pain relief. We actually did have a patient that came in to emerge in a pain crisis. She was a patient who had an undiagnosed breast cancer. It progressed. It did affect her nerves and was giving her like intractable nerve pain because this cancer had invaded her nerves around the breast. And, you know, a patient like that, a catheter nerve block actually would be a really good option. Phantom limb pain. So whenever you have whenever you have a patient who does have an amputation, they always have a risk of phantom limb pain. It's quite a well-known post surgical issue and chronic pain phenomenon. And so they had a study that ran a continuous infusion, again, of nerve block for 6 days in the ambulatory setting, and found clinically significant lower pain scores at 1 month post-operative. Unfortunately, it wasn't a long-lasting effect. At about 6 months, there wasn't a big clinical effect, but you ask anybody who has like phantom limb pain, they'll tell you that a month is worth it. And then there was also a really interesting case report of abdominal wall pain in pregnancy. So this is a patient who was a 23-year-old female who presented to the ER on multiple occasions for stabbing pain in her right lower quadrant. They continued to give her escalating doses of hydromorphone. She was up to 30 milligrams of IV hydromorphone a day, which is a huge amount. And so they kind of, as like a last-ditch effort, did a catheter nerve block inserted with ultrasound. Originally they did use bupivacaine, but then switched to repeated boluses of ropivacaine for 3 days. Her pain completely resolved, and she was able to completely come off her opioids and had an uneventful C-section at term, and her pain never did return. So sometimes it's all about kind of calming down those nerves. And then again, complex regional pain syndrome is another area of emerging evidence for using catheter nerve blocks. So case reports of continuous infusions of ropivacaine for about 2 to 3 days resulted in clinically significant pain relief, which, ask anybody who has chronic regional pain syndrome, again, they'll tell you they'll do anything. So it's a really cool area. Hopefully we can explore this a little bit closer to get an actual catheter program up and running in Regina. And yeah, hopefully we can do things a little bit better than we currently do. We're doing a good job, I think, overall, but there's just so much technology, so much new coming down the pipe that there's always room for improvement in the world of medicine. So that's that.
All right, thank you, Jill. Stop the recording here.